Welcome to the NWAETC Project ECHO. I'm Kent Unruh, and I'm here with a special guest, Chris Spitters. Dr. Spitters is Clinical Associate Professor in the Division of Allergies and Infectious Diseases here at the UW School of Medicine and is Medical Director of Public Health Seattle and King County TB Clinic. Chris.
Thanks, Kent. It's good to be here and glad to be joining the Northwest AETC ECHO Conference and speaking to you today about TB in the context of HIV. So without further ado, let's go ahead to the first slide and speak about why TB and HIV matter. What about TB matters in the context of HIV? Well, first and foremost, worldwide, it is the leading cause of death among HIV-infected patients. Now, fortunately, in the U.S., that's not the case. HIV co-infection is present in only about 10% of TB cases nationwide, and TB is not a common cause of death among HIV-infected patients, fortunately, in the U.S., but worldwide it certainly is. But for our HIV-infected patients, it's important to remember that TB infection and disease accelerates HIV-related immunosuppression by virtue of upregulating the target cells, the CD4 lymphocytes, thereby increasing viral load, and TB empirically is associated with decreased survival among HIV-infected patients, even when TB itself is not the cause of death. HIV, on the other hand, increases the risk and velocity of development of active TB after acquisition of TB infection, and HIV alters the clinical presentation of active TB. I'll be talking a little bit about that. So both infections have a negative impact for patients with respect to the other infection. They're mutually and negatively synergistic in their impact on patient outcomes. Now the next slide just takes a look at TB morbidity in our region by state for Washington, Alaska, Montana, and Idaho. And you'll see that two key things emerge. First is that Washington State and Alaska account for the majority of TB cases in the Pacific Northwest part of the United States, and that aside from Alaska, TB rates in this region are at or below the national rates. In fact, in Montana and Idaho, with only 21 cases total in 2010, they actually are near elimination of TB, but there are still, even there, a couple of dozen cases a year. An interesting difference between Alaska and the rest of the country is that most of the cases are U.S. born in Alaska. Many of those are U.S. born native Alaskans, whereas in the U.S. and most of the rest of the Pacific Northwest, being foreign born is a major risk factor for TB and accounts for the majority of cases. So back to that last point I made on the introductory slide about HIV and TB. I alluded to the HIV affecting the clinical presentation of TB. And to explore that a little further, let's talk first about the HIV-infected patient who does not yet have severe immunosuppression. That would be the patient in the right-hand column here who has a CD4 count as a marker of severe immunosuppression, who has a CD4 count above 200 per microliter. Now, as a group, these patients tend to present with TB like HIV-negative patients, predominantly with pulmonary TB in about 80% of cases. It's reactivation type disease where the disease is mostly in the upper zones of the lungs, often with cavitation. Extrapulmonary disease is present in only 20 or 30% of cases. Sputum examination often reveals positive smears. In my community, that's about 50% of the time. And there's less immune reconstitution inflammatory syndrome among patients who have TB, have newly recognized HIV infection, and then start antiretroviral therapy during their TB treatment course. Conversely, in the left-hand column, patients with severe immunosuppression indicated by CD4 counts less than 200, particularly patients with less than 50 CD4 cells per microliter, present more often with adenopathy and effusions rather than, say, lung infiltrates. They'll present with pleural effusions and intrathoracic adenopathy, with or without cervical and abdominal adenopathy. Multi-system organ involvement, possibly involving the central nervous system, spleen, liver, other organs, other extrapulmonary sites, more common. Overall, among severely immunosuppressed patients, up to 50% have extrapulmonary involvement. Sputum smear negativity is much more common. Probably the majority that do not have overt pulmonary parenchymal infiltrates will have negative sputum smears. And iris is much more common. And that makes intuitive sense if you think about these patients although they have high bacillary loads, they have a high TB bacillary load, they do not have a robust immune response. You treat the TB, there's still a lot of killed TB antigen around. Then you come in after that with antiretroviral therapy and restore the cellular immune response, and they get a rebound inflammatory response. And up to 20 or 30% of patients in this category will develop immune reconstitution inflammatory syndrome, typically 2 to 4 weeks after starting antiretroviral therapy. And as a follow-up to that slide, I left that hanging. We'll talk a little bit later about the timing of initiation of antiretroviral therapy in TB HIV patients who are diagnosed with TB but who are antiretroviral therapy immune or who have fallen away from antiretroviral therapy. But let's jump back to the typical patient who's not severely immunosuppressed. Here's a chest radiograph of a patient with this gentleman is about a 35-year-old man. He had had a cough, sputum, fever, night sweats for 2 to 3 months. He had lost about 10 pounds, but you can see from his lean body mass he still had reasonably good overall body mass. He had a right upper lobe infiltrate that was sputum smear positive. He started 4-drug anti-TB therapy with isoniazid, rifampin, pyrazinamide, and ethambutol when his positive sputum smears came back, and he did quite well on TB therapy. But and at the time of his TB diagnosis, HIV serology was drawn, and he was newly recognized as HIV positive, but really presented like any TB case might have presented in an HIV negative patient. His CD4 count, as I mentioned, was up in the 300s. Now after 2 months of initial TB therapy, he transitioned to the continuation phase of TB therapy that I'll discuss in a minute and started antiretroviral therapy, had an uneventful course with a good response to both sets of therapy, and is now done with TB therapy. Did very well. Next slide, we'll look at the typical chest imaging of a severely immunosuppressed patient. This is about a 28-year-old man who was a household contact of a patient like the one we just mentioned, sputum smear positive, pulmonary TB, and but this man was known to be HIV positive, was not in care, had a CD4 count in the mid-40s, and he presented with fever, chest pain, and dyspnea, as well as abdominal distension, nausea, and vomiting. And you can see on his chest imaging a couple of key features here. First, and most obvious, right greater than left bilateral pleural effusions. He also has some widening of the cardiomediastinal silhouette, suggesting that he has intrathoracic adenopathy, and then there's a hint of maybe some right-sided lung infiltrates there. And then last but certainly not least, if you look at the lateral film, you can see that his abdomen is distended there, and he had ascites as well. Now, when we look at his CT imaging, which we would suggest you get in a patient like this to get a better view of just what's going on inside his chest and abdomen, the chest images showed these bilateral effusions, not too many parenchymal infiltrates. There was just some atelectasis in the lower zone created by the pressure from the fluid on the right side, but he did have extensive adenopathy in the right paratracheal area and then the left prevascular zone. I'm not going to show you the abdominal cuts, but he also had ascites and splenomegaly as well as retroperitoneal adenopathy. So, a couple of clinical presentations, some imaging. I think you get the idea of how the workup starts in a suspected TB patient and the kinds of findings you expect to find based on the level of immunosuppression. But let's talk a little more in detail about what to go after when you're suspecting TB. Once you've got the imaging and you've got an idea of based on the clinical history, exam, and imaging of where the disease is, then you want to go after specimens for AFB smear and culture, and then when assuming the culture is positive for TB, you want drug susceptibility testing. But those specimens need not only come from sputum, but they can also come from extrapulmonary sites, such as pleural fluid, lymph node biopsies, lymph node aspirates, spinal aspirates, urine, peritoneal fluid, bone marrow biopsies, to name the majority, but not an exhaustive list. But those are the most common sites. Cerebrospinal fluid as well. And what you're looking for to have done on those is the vast majority are amenable to AFB smear and culture, as well as nucleic acid amplification, polymerase chain reaction in most laboratories. And then you want to pursue ancillary testing that gives clues about the etiology before the mycobacteriology results come back. Chemistry, protein in particular, LDH, cell counts, cytology, cytology on fluids, pathology on tissues, and again, a typical constellation of findings you would find from a fluid would be high protein, typically greater than 5 grams per deciliter, a lymphocyte predominance in fluids, like maybe greater than 50% of the white cells. And so we call those lymphocytic exudates. That's a typical finding on pleural effusions and peritoneal effusions. On pathologic examination, tissues will typically show granulomatous inflammation, often with necrosis, but not always. Sometimes with acid-fast bacilli, but that's in the minority of cases. The absence of AFB and the absence of necrosis does not rule out TB. And remember that severely immunosuppressed patients often cannot form a good granuloma. So even the absence of well-formed granuloma does not rule out TB. Other testing to pursue on these fluids, you can consider getting an adenosine deaminase, which will often be elevated in patients with pleural or peritoneal TB. And then you can talk to your reference laboratory. It's usually your state public health reference laboratory about getting expedited molecular testing for drug resistance in special circumstances where there's a high concern about drug resistance, particularly multiple drug resistance. That would be patients who have been previously treated for active TB, patients who are from regions where there's a high degree of multi-drug resistance like Eastern Europe, South Africa, to name a couple of examples. But that needs to be arranged for on a special basis. And then pursuing, although it's insensitive in severely immunosuppressed patients, pursuing tuberculin skin testing and or IGRAs, that's interferon gamma release assays. I'll talk about those in greater detail in a few moments. And then other routine testing that's part of the workup of a patient with a febrile syndrome that raises the concern for TB. Okay, moving on to the next slide. So once that specimen collection has been completed, you're usually going to base the working diagnosis upon the imaging, the overall clinical picture, and some preliminary findings from the laboratory work. You're most often not going to have a definitive mycobacteriologic diagnosis to guide therapy, but a working diagnosis that guides empiric therapy while cultures are pending. And that therapy usually begins with 4 of the 5 first-line drugs, as we call them: isoniazid, rifampin, pyrazinamide, and ethambutol. The other drugs in the armamentarium there, streptomycin and the second-line drugs, are really there for use in patients who have drug resistance or who have intolerance to the first-line drugs that render them either unuseful or unsafe for the patient at hand. This graphic shows you the typical standard regimen for a case of active TB that it turns out to be fully sensitive to all first-line drugs. You see in vertical orientation the 4 drugs: isoniazid, rifampin, pyrazinamide, and ethambutol, with their abbreviations in what we call the domestic or U.S. abbreviations, and then sometimes in the international literature you'll see them referred to as HRZE. That term HRZE means the 4-drug regimen, starting out with 4 drugs that continue for 2 months, and then in the fully sensitive patient, the pyrazinamide and ethambutol stop, with the isoniazid and rifampin continuing for at least 6 months, and then depending on response to therapy, immunosuppression, etc., 6 to 9 months of total therapy for the average patient. Therapy can extend out as long as 12 months for patients with CNS disease or severe spinal disease, but most patients complete therapy in 6 to 9 months. The next slide is only to give you a picture of the alternative and the thing that in my profession in public health disease control, public health TB control, we're trying to avoid, which is the creation of MDR TB that requires treatment for 24 months, as you see along the bottom of the x-axis, with multiple drugs that are less efficacious, of higher toxicity, more expensive, and just more inconvenient for the patient, harder for the clinician, harder for everyone. And this just gives you an idea of in a graphic sense, the intensity and duration of those regimens. But I won't discuss those further at this time, other than to say, if you're facing a situation like this, consult an MDR expert. And this whole discussion about treatment of active disease really goes forward assuming that you coordinate treatment of active TB patients with the local public health entity that supervises therapy, investigates contacts to make sure they get evaluated and treated, and assures the adherence of your patient to the treatment regimen that you or the infectious diseases specialist that's working with you is prescribing. So, earlier in the talk I said I promised to come back and talk about initiation of antiretroviral therapy in patients with TB who have either newly recognized HIV infection at the time of TB diagnosis or who have who are not on antiretroviral therapy but who would benefit from it. And I just want to start the conversation by reviewing some key WHO recommendations released in 2010. Number one, start antiretroviral therapy in all HIV-infected individuals with active TB, irrespective of the CD4 count. And two, starting that TB treatment first, getting the TB under control, and then following that with ART as soon as possible afterwards, but within the first 8 weeks of therapy. And you'll note that that recommendation comes with a moderate quality of evidence. And I want to follow this slide with an update on that evidence and modify that recommendation, if I may. And then finally, to just emphasize that in building a standard antiretroviral regimen for a TB patient, it's strongly recommended that unless there are reasons to do otherwise, a 2 NRTI plus efavirenz regimen is the preferred approach, because that's the regimen least likely to have adverse drug interactions with rifampin, and so that's in the best interest of the patient. Well, what about timing of initiation? The WHO guidelines that you read said as soon as possible, but definitely within 8 weeks. Well, those guidelines were written in 2010, but in late 2011, several studies were published looking at just this question: what is the best time to start antiretroviral therapy in the newly recognized HIV-TB patient? What is the best balance of expediting treatment of immunosuppression on the one hand, and getting the benefits from that, not only from reducing viral load and raising CD4 count in order to help cure TB, but as well as to forestall the risk of other opportunistic infections on the one hand, but then on the other hand, you've got pill burden, competing multiple toxicities, and then this risk of IRIS on the other. So where's the best balance? And the studies are summarized in this tabular graphic, which shows that the 3 studies that looked at this unanimously showed that in patients with CD4 counts under 50, there is strong evidence that starting certainly less than 8 weeks, and possibly even right away within 2 weeks, is in the patient's best interest, that the survival benefits, the HIV-free or the AIDS-free survival benefits outweigh the toxicity and IRIS risks associated with that early initiation. IRIS will occur more frequently, up to 4 times more frequently, even with fatalities associated with that IRIS, but overall mortality is lower in the group that gets the early antiretroviral therapy when CD4 counts less than 50. But at CD4 counts above 50, there's strong evidence, 2 out of the 3 studies that looked at patients with CD4 counts under 200 to 250 showed that the risk-benefit actually favors waiting until the continuation phase of TB treatment, waiting until the 3rd month to start antiretroviral therapy, to have a slightly lower incidence of IRIS, less toxicity from drugs, from having multiple simultaneous initiation of drugs, and so that's I think the current or the next version of the WHO guidelines, I would suspect, is likely to say below 50, start as soon as possible. Once TB therapy is established and tolerated, start antiretroviral therapy. That's what I'm seeing my HIV colleagues do now. But if it's above 50, in most cases, I think that the wiser thing to do is get TB treatment underway for a couple of months and then start antiretroviral therapy. One study that had impressive results looking at CNS TB. And again, we're thinking about iris, and in the CNS, iris can be a serious, if not fatal, condition because of the closed space there. There was strong evidence that starting antiretroviral therapy during the initial phase of TB therapy, during the first 8 weeks, is actually a bad idea. So that it's not in the table here, but that would get a D1. So it's a randomized controlled trial with evidence showing that it's a bad idea. So that's a D rating for starting during early therapy, and A1, the converse, showing it's a good idea to wait until CNS disease is controlled to start antiretroviral therapy. Okay, the next slide, for those of you that have time, I encourage you to at least access those abstracts on PubMed just to read them, to get a feel for the data that's behind that table that I showed you, and those are the references. Let's move on from active disease to latent TB, which is what you're going to be dealing with the majority of the time, not active disease, but trying to find and exclude latent TB, or if you find it, treat it. First, what about the choice of test? For years, we've dealt with the tuberculin skin test, the administration of purified protein derivative, or PPD, which is just a protein-rich supernatant, basically, of a TB culture, injecting that in the skin and looking for a bump to arise. Now we've got the option of basically doing a TST in a bottle with the IGRA, the interferon gamma release assays. Which is better? Is one better than the other in the diagnosis of HIV? Good question, to which there's not a definitive answer, but let's talk about what the data says. There's a multitude of studies looking at this, over 3 dozen. A systematic review of those studies published last year in the Journal of AIDS asked 2 questions. One, are IGRAs better than TSTs at predicting which HIV-infected individuals are at risk of progressing to active TB? Because in the end, that's what we're trying to prevent. And 2, are IGRAs more sensitive than the TST for diagnosis of MTB infection, particularly in those HIV-infected individuals with advanced immunosuppression? And the answer, as you might imagine, was that there's insufficient evidence to favor one over the other. The observation, a qualitative observation that came out of the meta-analysis, was that IGRAs may be less prone to perturbation, which is my paraphrasing of false negatives due to immunosuppression. There may be less false negative IGRAs than there are false negative TSTs in severely immunosuppressed patients, but the jury is still out somewhat on that. What are the implications of all this? One, there's no evidence-based argument for which I can tell you you should definitely choose TST over IGRA or vice versa when testing HIV-infected patients for latent TB. My personal advice is to be practical and remember that what you're trying to avoid is active TB in a severely immunosuppressed patient. So if you are testing a severely immunosuppressed patient, consider dual testing with acceptance of either positive as a result of evidence of infection. And when you're doing testing, try to keep in mind the patient's background epidemiologic risk. Born and raised in northern Idaho, who have never worked in a healthcare setting or never traveled to a TB endemic region, you have a low pretest probability there. Test judiciously and interpret with caution. A patient with 50 T cells who's from Somalia and has HIV, do both tests and interpret either one as being positive as evidence of infection. And when in doubt or in question or uncertain about the availability of one test or another, consult with your local or state TB control program about how they're handling such situations. Now you've got a patient with a positive TST or IGRA, let's say, and they're HIV infected, or they're not. We can broaden the discussion for a minute and say now you've got a patient who you think has latent TB, they're asymptomatic, they've got a positive test for TB by virtue of a positive tuberculin skin test or a positive IGRA, and you want to think about what to treat them with. Well, these are your regimen options. Isoniazid given daily or twice weekly for 9 months is the tried and true regimen that we've known for 40 or 50 years works. Rifampin given daily should work well. It's got advantages in its shorter duration, better tolerance and safety. A disadvantage in that it can interact with protease inhibitors and other drugs metabolized by the cytochrome oxidase system, so you'd want to avoid its use in patients taking those drugs. And then isoniazid and rifapentine offers a once-weekly option that is given for 12 weeks instead of for 4 months or 9 months, so it's shorter. It's once weekly. The downsides are it must be directly observed, so you have to have the patient come into the clinic once a week or have some outreach mechanism. And then the rifapentine component, again, has that cytochrome oxidase drug interaction potential with protease inhibitors and other drugs, so you'd have to watch out and avoid that regimen for such patients. In any individual patient, if you're up in the air about what to do, again, consult an expert, your local TB control program, what have you. But those are the options. And prior to starting any of them, these are some caveats for latent TB treatment. One, don't start latent TB treatment in any patient that's not in their baseline health. That may not be excellent health, but baseline health. For 2 reasons. One, you don't want to inadvertently treat a patient who, whoops, they do have active TB. That malaise, fatigue they had was extrapulmonary TB, and I treated them with isoniazid monotherapy. You don't want to have those regrets. The other is if they are not in their baseline health due to some other condition, get through working out that condition. That's a higher health priority, something that's actually going on now. Plus, if they're not feeling well from that condition, they may attribute that condition's symptoms to the drug and say, hey, that drug's given me, that isoniazid or that rifampin's given me side effects. I don't want to take it. So you're just going to have better luck overall. Wait till patients are in their baseline health. 2, exclude active TB. How do you do that? A basic clinical evaluation, history and physical exam to look for symptoms and signs of active TB. What are those? Cough, sputum, fever, night sweats, right? Rule that out. Get a chest radiograph and, look for lymph nodes, look for tender spine, abdominal distension. If you've got none of that, you've got a normal x-ray in a patient who's afebrile and not coughing and not losing weight, you can start isoniazid or one of the other drugs. Other caveats, INH, great drug. It works well. 9 months of isoniazid reduces the risk of active disease by 90%. It's also got the highest risk of liver injury. In someone 35 to 50 years of age, about 2% risk of liver injury. Keep that in mind. Advise patients to, keep aware of symptoms of liver injury, nausea, anorexia, severe fatigue. If that happens, don't wait to the next visit to tell me, because you may be jaundiced and in severe liver failure by then. If you start to feel nauseated and fatigued and lose your appetite, stop taking it, call me. Don't start taking it again until I've seen you. And when they come in to see you, then check their LFTs. Give them pyridoxine with it to avoid peripheral neuropathy. Check LFTs monthly and PRN. The once and twice weekly regimens I mentioned, if it's INH twice weekly or INH plus rifapentine once weekly, really should be supervised with direct observation. And again, beware of those rifamycin-based drug interactions. And again, cannot emphasize enough, every patient that I've seen that's had a severe drug-induced liver injury due to isoniazid, there was a communication problem that either led to or exacerbated the severity or duration of the drug-induced liver injury. So clear, repeated messages about what to do if they sense symptoms of liver injury. Stop the meds, call the clinic, get an appointment, don't resume until cleared to do so. And if you think they do have drug-induced liver injury with the symptoms and elevated transaminases, don't resume it. Call an expert, call the local health department, get advice on where to go from there. So, in review, a couple of key points to take home. One, remember that TB presents differently in severely immunosuppressed patients. It's not upper lobe infiltrates with cavitation and positive smears. It's effusions, adenopathy. It can be a very nonspecific febrile illness. Okay? And two, the standard initial regimen for active TB in all TB patients, HIV infected or not, is those 4 drugs: isoniazid, rifampin, pyrazinamide, and ethambutol, plus the vitamin B6. Always involve the local or state TB control program from the outset to help you with the adherence, case management, and contact investigation aspects of this public health personal medicine dyad that TB treatment is. Remember about rifampin, rifamycin, antiretroviral drug-drug interactions, and account for those. And if you're not experienced in doing so, then be on the phone or in direct consultation with someone who is, so that your patient's HIV TB medication management is appropriate for their situation. If you suspect drug resistance or witness drug resistance or have drug intolerance that's going to require a regimen change, get expert consultation. Among your patients who have epidemiologic risk factors for TB and who are HIV infected or not, for that matter, test for latent TB and offer treatment if they're good candidates for completing latent TB treatment. And consider using both tests, the IGRA and the TST, for severely immunosuppressed patients. Lean toward use of isoniazid for most patients with latent TB and HIV to avoid the rifamycin antiretroviral therapy drug interactions. But when there's active liver disease or a low potential to complete this long 9-month regimen, then start thinking about the alternative rifampin for 4 months or isoniazid plus rifapentine for 12 weeks.